Welcome to this episode of Oncology Data Advisor. Today, in honor of Prostate Cancer Awareness Month in September, I'm joined by two of our editorial board members, Dr. Steve Freedland and Dr. Ulka Vaishampayan. They're here today to discuss some recent advances in prostate cancer screening and treatment, as well as insights into disparities and health equity. So thank you both so much for coming on today. I'm looking forward to hearing this discussion.
Well, thanks so much for having us. And it's great to share the stage here with you, Ulka.
Thank you.
Yeah, I'll kind of go first. And in many ways, our goal as urologists is to keep our patients away from the medical oncologist. Hopefully, we can diagnose it early and cure them, that they don't need all the great advances that you're going to tell us that are coming down the pike. But if they do, that they do. But
Yeah.
so one of the challenges we have is how to find the cancer in the first place. And we're making strides. There's been a lot of effort, certainly in terms of MRIs and how to interpret that. And I think that's increasingly becoming the standard of care. We are starting to see some data emerge that's a little bit concerning, that certain ethnic groups aren't getting as equal access to MRIs. So I think that's concerning. There may be some other factors at play, certainly insurance status. So I think that's an area that's evolving in terms of making sure our patients have access to those latest, greatest technologies. A lot of the research in terms of the early detection would be focused on biomarkers on one side, but also, PSMA imaging, PET scans are certainly revolutionizing biochemical recurrence, finding metastatic disease. And so there's a lot of interest. Can we actually use that to find localized disease? Can we get to the point where between an MRI, a PSMA PET scan, you don't even need to do the biopsy, that you're so convinced this patient has cancer that we go straight to the operating room? And you think about it, we do that in kidney cancer, right? We don't typically biopsy a kidney cancer. It's a big mass, it looks bad. You have a nephrectomy. I don't think we're there in prostate cancer, but that's some of the questions that I think that people are looking at and really trying to understand. There's certainly a lot going on with biomarkers, kind of looking at novel biomarkers. It's hard to read a journal these days without some discussion of biomarkers, either the existing ones or new things coming down the pike. I don't want to necessarily say one is at this point is better than the other. I think all of us in the field kind of have our favorites. But where we're struggling a little bit in the field is, do you do the biomarker before you get an MRI? Is it after the MRI? How to incorporate all of this information? Because now we not only have the PSA and the PSA trajectories, the field has certainly moved away from a cut point of 4.1 gets a biopsy, 3.9 doesn't. It's a continuum. Obviously, you're going to repeat the PSA. That's really become standard. And it's amazing how often that PSA comes down. When you simply repeat it, refer to PSA of 5, you repeat it, it's back down to 2. Patient's happy, you're happy, and you go on to the next patient. But for those where it doesn't come down, biomarkers, and I don't think there's a consensus in the field right now. Do you do the biomarker first? Do you go to the MRI first? Who needs both of those tests? I think that's certainly increasing healthcare costs, but there's sometimes you do one of those, biomarker MRI, and it doesn't give you the full information. You're still kind of in a conundrum of what to do. So I think that's where some of the field is looking at, is how do we have better biomarkers? How do we combine them with MRI? There was a nice study recently published that looked at transperineal versus transrectal biopsies to show the benefit to transperineal. I think that's where the field is going. I think it's requires some change in the technology of what we've been doing in the standard transrectal biopsy done in clinic. So now moving to trying to do transperineal, it's a little bit more painful. So you got to understand the anatomy. You got to, in terms of numbing, is a little bit different. But I think that's where the field is moving, trying to reduce those infectious complications we see from the transrectal, and doesn't seem to really impair cancer detection. I think that's the important thing. So if I had a crystal ball, where we'll be in 5-10 years, I think it would be all transperineal. And then I think in terms of advancements, for those that diagnose, we still, for those that need it, we still have our genomic tests. There's 3 commercially available ones out there. You get Decipher, Polaris, and GPS, still being widely used. And I think the next step in those tests, you're starting to see a little bit of this, is can it be predictive? Can we actually use it to say, not just you have bad disease, but you're going to respond better to this treatment or that? Decipher's found its way into guidelines kind of with that, but I think that's an area of research that they're all looking at. And then as you get into those diagnosed undergoing treatments, a lot of interest in focal therapy, really starting to show some benefits, but I would say it's still early. We're certainly doing it at Cedars-Sinai with my colleagues, and I think it's increasingly being used. But who, if you're doing focal therapy, how do you surveil the contralateral side? What does a rising PSA mean? I think there's a lot of unanswered questions we're trying to answer. And then as you move to those getting surgery and radiation, right now we're awaiting the results of phase 3 trials to understand, do we need intensified androgen deprivation therapy? You got the Proteus trial ongoing for surgical patients. Hopefully we'll have an answer to that soon. That's looking at apalutamide in addition to ADT for surgical patients. And then we have radiation studies. We certainly know very high risk benefits from abiraterone, from Stampede, but we have 2 ongoing phase 3 clinical trials with Atlas and Enzarad, looking at apalutamide and enzalutamide respectively for kind of your standard high risk, not your super high risk. And then at that point, if the patient fails, there's newer therapies, but I will turn it over to Ulka at that point. I'm happy to talk about the biochemical recurrence as well. It's kind of one of my favorite places to live in the world. But I will turn it over to you, because now we're in the realm of systemic therapies. So what's the latest there, Ulka?
So I think there are a lot of advances in systemic therapy in advanced prostate cancer, starting with biochemical relapse, where now, as you know, Steve, very well, there was a study that led by you that looked at randomizing people to enzalutamide only or LHRH analog or the combination. And the combination did very well with long-term better outcomes in terms of progression. But also, not only did it delay progression, but it allowed patients to be on intermittent therapy. So they got an opportunity to somewhat recover from their testosterone suppression in between. The enzalutamide arm alone also did better, significantly better than the LHRH analog therapy alone. So that gives patients another option of getting just an oral therapy that does not suppress their testosterone, which, of course, as we know, testosterone suppression has multiple, both short-term and long-term effects, mainly the hot flashes, mood changes, fatigue, etc., as well as the potential long-term effects of increased cardiac events, metabolic syndrome, and bone loss or bone weakness, and increased risk of fractures. So with taking into all of that into consideration, I think it is important to look at patients' other comorbid conditions and then make a treatment plan that suits the patient. I think individualizing treatment plans has become more and more critical in prostate cancer, mainly also because we are diagnosing metastatic disease much earlier now with the very sensitive scan, the PSMA PET scan. At this point, though, clinically, we do not know what kind of outcomes to expect by treating patients early in the metastatic disease, where we've only found it on the PET-CT and no evidence of disease on standard conventional imaging, which is the CAT scan and the bone scan that we've been using for years. So there is a little bit of a dilemma, but I think with the individual patient risk, looking at the Gleason score, looking at how aggressive the prostate cancer looks, and using other biomarker characteristics will help us sort of determine the perfect optimal treatment design for our patient. The other thing to be kept in mind is that genomic sequencing is becoming a critical piece that every patient with metastatic or advanced prostate cancer should be getting genomics testing now. One, to determine if they have another option for therapy, such as the BRCA1, BRCA2 mutation patients would potentially be treated with PARP inhibitors and maybe even in combination with hormonal therapy. The other reason is that, of course, if they have a hereditary risk of predisposition to cancers, it can impact other family members for breast, ovarian, colon, prostate cancer risk. So it is a critical piece of prostate cancer management, especially in the advanced setting or the high-risk prostate cancer setting. So NCCN guidelines allows us to test for either of these case scenarios. The other sort of advance is that there is imaging-based therapy now. So radiopharmaceuticals have made a major advance, and currently FDA approval has been given to patients post-chemotherapy, patients who did not have any other therapeutic options, who could get radiopharmaceutical therapy. The PSMA lutetium is FDA approved currently and has shown a benefit in progression-free and overall survival. So that is another treatment option. There are multiple other hormonal therapies and PROTACs or AR degraders that are coming down the pipeline. So definitely look for clinical trials, which are the cutting edge therapy for patients with metastatic prostate cancer. Upfront treatment for metastatic disease has become very aggressive with at a minimum two treatments and maybe potentially the triplet therapy with androgen suppression plus an oral anti-androgen and chemotherapy with docetaxel-based regimen. So those are sort of the big changes that a lot of our previously established treatments have moved earlier in the treatment setting. I think this is one disease also where a racial disparity has to be taken into account. African Americans have a very much higher incidence of prostate cancer. Usually you should consider even to start screening at a lower age for African American patients, definitely for the ones with family history, and consider being more aggressive in their treatment. We actually did a study when I was at Carmanos Cancer Center, where about 30% of the metastatic castrate-sensitive patients were required to be African American, and we accrued to this study, and we showed that African Americans, to have an equally good outcome in metastatic prostate cancer, you need to have the combination of LHRH analog and an oral anti-androgen therapy. In our case, we did the study with LHRH plus enzalutamide, and the combination was actually much superior or similar to the non-African American patients who went on the study. So definitely from a screening standpoint, as well as overall in metastatic disease management standpoint, that is important to keep in mind and try to overcome their access to care and transportation barriers, because they need that treatment and need to be intensified treatment sooner rather than later in their case. The other thing I will think about is there is a specific, very resistant disease called neuroendocrine prostate cancer. And it could be argued that a lot of prostate cancer patients potentially, as they get castrate resistant and pretreated, potentially fail because the neuroendocrine component within prostate cancer is becoming the predominant driver of the disease. And really, there has not been a whole lot of advances in this area. We've used platinum-based chemotherapy as sort of the standard treatment currently, but outcomes are pretty dismal. Majority of those patients progress in 3 to 4 months or less, and they are severely symptomatic from their disease. Now, their PSA levels are low, so you definitely have to be vigilant and look at patient symptoms and how they are doing from a constitutional standpoint, where if they're having fatigue, losing weight, not doing well, it's important to do a scan, even if their PSA is undetectable. So with this type of disease, we recently have been conducting a study of using immune checkpoint therapy in this disease. Typically, immune checkpoint therapy is not very effective in metastatic castrate-resistant prostate cancer. It has been tested, and the response rates have been very low. In neuroendocrine disease, however, just extrapolating from small cell cancer of the lung, it appears that immune checkpoint therapy could be effective, and our study evaluates a combination of lenvatinib and pembrolizumab in this setting. So those study results will shortly be reported, but overall, there have been some promising results with immune checkpoint therapy in neuroendocrine prostate cancer. So definitely, if you have one of those variants of prostate cancer, it is important to seek out clinical trials. There are some other cutting-edge clinical trials ongoing in this arena, and it's important to look into those and consider those, because that's how advances are made in any cancer. Thank you.
Yeah, no, that's great, Ulka. It's a great summary. And I think, the very poignant thing for me was when you start talking about the racial differences, and we see that when we know Black patients are much more likely to be diagnosed with prostate cancer.
Yes.
But once they're diagnosed, and you saw it in Hermanos, you see it in the context of clinical trials, we see it within the VA, when treated equally, that's the big caveat, outcomes are the same, if not actually even better.
Yeah.
But we got to get to that equal treatment, and we're not there as a country.
No,
we're not.
I agree. I mean, also clinical trial participation, we do a very poor job of involving them and engaging Black patients in clinical trials.
No, I mean, it's a challenge. And I mean, there's just, real world barriers. I mean, there's health literacy, there's socioeconomic status, just getting in to see the doctor, being able to take a day off work. And there's just a lot of real barriers that I think we need to pay attention and really help our patients overcome.
Yeah, I think there is something to be said for, us going to the patient rather than the patient continuously approaching us for clinical trials. So if we maybe change that design, we'll potentially engage more people. But you're absolutely right. If we give them the right intensified treatment, and my feeling is even in the biochemical relapse setting, potentially we could make a bigger dent in Black patients if we intensify sooner rather than waiting until they're metastatic.
Oh, absolutely. And it's identifying that. But I think, going out into the community. And so I've done that, not as much as I should have, but it's interesting to go
all of us,
we went out to the first African Methodist Episcopal Fame Church in Los Angeles, and to talk to them about clinical trials and what's involved and things. And it was a pretty good turnout, and it was interesting, so we certainly need to do more of that for sure.
Yeah, so true.
Yeah,
and hopefully with this Prostate Cancer Awareness Month, all of us will think about expanding our approach, quality of care to all patients within the community.
Absolutely. Very crucial. So, well, thanks so much for joining me here. And thank you, Kira, for moderating this.
This was great doing this session with you.
Yeah, this was fun. So appreciate all you listeners for tuning in.
Awesome. Thank you so much.